Eileen is one of the pediatric emergency medicine experts at USC, and she's going to cover something that's obviously very important in pediatric medicine, and that's respiratory emergencies.
So it's really early for a Saturday morning, especially in Vegas. What I wanted to do is cover a few cases that I saw in the emergency department that really got my adrenaline pumping, really woke me up. Hopefully it will invoke memories in you of similar situations. So 4 a.m. guy, this is for you. All right, you have a 12-month-old presenting with shortness of breath. They have 2 days of kind of URI symptoms, a fever, poor POs, and now they have a hoarse voice, a barky cough. Review of systems is pretty much negative, no past medical history, it's an immunized kid. Your vitals are there, the child's febrile, tachycardic, tachypnic, mildly hypoxic. On exam, you hear some inspiratory and expiratory stridor. The kid has retractions, otherwise the lungs are clear, and the rest of the physical exam is negative. So what stands out to me here? Well, it sounds like a kid with croup, right? And of course the vital signs are all abnormal. But vital signs look like this in pretty much every child that's 1 and has a fever. The thing that really stands out to me here is the mild hypoxia. Now, residents often look at me a little bit strangely when I get excited about a saturation of 92%. Certainly, we send kids home with bronchiolitis in this saturation. But the problem here is that croup is an upper respiratory disease, and the saturations in general should be normal. So when you see even mild hypoxia in a patient that you think has croup, it's telling you something. And that saturation monitor is telling you to be afraid. So you write some initial orders, IV, O2 monitor, maybe a chest x-ray. We're going to give some steroids and perhaps some inhaled epinephrine. And your initial gestalt to be afraid was entirely correct because this patient doesn't get any better. So let's talk for a minute about croup. Croup is a viral laryngotracheal bronchitis. Sometimes the bronchi are affected, sometimes they aren't. Depends how bad it is. It's mostly caused by the 3 different strains of parainfluenza virus. There are other viruses that can cause it, and when it's caused by influenza A, it tends to be particularly severe. The thing we really worry about in croup is the edema in the larynx and trachea. It tends to affect kids between 6 and 36 months, and like I said, there's a lot of viruses that can cause it, so about 5% of kids will actually have not 1 but 2 episodes of croup. The history is typically what we saw in this kid here. Some nonspecific respiratory symptoms followed by a fever, a hoarse voice, a barky cough, and often stridor as well. And it tends to wake the kids up. It tends to get a lot worse at night. The symptoms progress for the first 3 days, then it peaks, and then the symptoms dissipate over about a week to 2 weeks. Kids can become superinfected either with pneumonia or bacterial tracheitis, and there is a non-infectious version called spasmodic croup that tends to be recurrent and wake otherwise healthy children up in the middle of the night with a barky cough and stridor. On physical exam, you may or may not see stridor. In mild cases of croup, they tend not to have any stridor. Moderate cases, you might see stridor on exertion when the kid's coughing or crying. And in severe cases, you can hear a biphasic stridor, often even at rest. They can have a slight expiratory wheeze, so don't let that dissuade you from your diagnosis of croup. And the ominous signs that you really want to look for, hypoxia, lethargy, and severe retractions. They let you know that the kid either has something complicating the disease or they have a really, really bad case of croup that you're going to need to deal with. This is a clinical diagnosis. An ABG is certainly not necessary. There aren't really any labs that are necessary. If it's in the middle of influenza season, you might want to do a flu swab because certainly that would impact your management. If you decide to do an x-ray, which isn't required, you may or may not see the classic steeple sign. It's a very nonspecific and insensitive finding. So it might be there, but it's often there as well in a lot of normal kids that happen to be expiring when the x-ray is taken. In terms of treatment, you really want to keep the kid calm and comfortable. And I know that's easy to say, but when a sick kid comes into the emergency department, what's the first thing we do? We separate them from mom, we throw them on the gurney, we start putting them on monitors and sticking them with needles. This is kind of a situation where that could cause the kid to lose their airway. So what you want to do is try to leave them on mom. You can slap a monitor on while the kid's sitting on mom's lap. In fact, you can start an IV if you need to while the kid's sitting on mom's lap. So try to keep the environment as calm as possible. When I was in training, cool mist was the mainstay of therapy. I remember I did a pediatrics residency as well, and I would round on the wards, and I would have these kids in these mist tents. And you'd actually walk into the room and there'd be a big tent full of steam. You couldn't even see the child. They could have been abducted 5 hours ago. Nobody would have noticed. So in addition to the obvious safety issues regarding these mist tents, we've since discovered that cool mist is useless in the treatment of this disease, and hopefully that's no longer being done. What is helpful is steroids. Dexamethasone seems to be the best, and you can give it orally, IM, or IV. The standard dose is 0.6 milligrams per kilo. Doses all the way down to 0.15 milligrams per kilo have been tested and seem to work just as well. But unfortunately, it's going to take a few hours to work, of course, so you want to get it on board as soon as possible, but you're not going to see the impact for a while. So in a child with more severe croup, and for me the trigger is significant respiratory distress or stridor at rest, you want to temporize them with some inhaled epinephrine. That's going to last somewhere between 90 minutes and 3 hours, and the hope is that if you're able to make the child comfortable, as the epinephrine wears off, the steroids will kick in, and at about 3 hours, that kid will be dischargeable. Probably not so much in our patient. Now, we have racemic epinephrine, and that's what I tend to use, and the dose is 0.25 mLs for a small kid and 0.5 mLs for a big kid over about 4. If you don't have racemic epinephrine, you can also grab the 1 to 1,000 epinephrine off the code cart and nebulize that. And that's 2.5 mLs for a little kid and 5 mLs for a bigger kid. Heliox, which is a helium-oxygen blend, is kind of controversial. It may be helpful, and if you have it and you have a sick kid, it's probably worth a try. So let's get back to the case. This kid looks bad, and you decide to intubate. We know the formula for an ET tube size in children is going to be the age in years over 4 plus 4. So this kid calculates out to 4.25. So maybe we're thinking of 4.0 ET2. But remember, that's a size for an uncuffed tube. And now that we know that cuffed tubes are pretty safe in pediatrics, as long as you can control the cuffed pressures, many emergency departments are stocking cuffed tubes. And if you use those, the physical cuff itself is going to create some space, and you need to go down by half a size. So now we're at a 3.5. But this kid is going to have a lot of upper airway edema, right? So we're going to want to go down another half size or even a full size to compensate for the edema. So now we're down to a 2.52. If we get in there and there's a lot of secretions, that's going to be kind of difficult to suction through such a small tube. And if we can't pass that, it's going to be hard to go down much further in size. So this would be a case where I might look around for an uncuffed tube, just so you can use at least a 3.0, a slightly bigger size. Now, Marianne is going to lecture later today on airway and tackling some difficult airways, but I just want to mention a few points that I like to think about that I think are especially important. In terms of positioning the child, we all know that kids have giant heads, and the only way to keep their giant head from flexing and making them impossible to intubate is to put something under their shoulder. So put a little towel roll under there. I like to pass an NG tube before I've sedated and paralyzed the kid. I am always impressed how much air they can get into their stomach and how much that can go up and fill the thoracic cavity and make it difficult to expand the lungs. Multiple times I've actually intubated a kid, and even though I was in, I had trouble telling because the kid was very difficult to ventilate because of the giant stomach. So here's a kid who's been crying, they've been coughing, and you probably are going to have difficulty pre-oxygenating them and will probably have to bag them as well. So this is a kid that I would decompress the stomach before I even start with the intubation. Kids have a fairly low risk of aspiration, and this is generally a safe thing to do in pediatrics. Also, you're going to anticipate that this is a difficult airway. Kids in general are pretty easy airways, and Marianne will tell you later today that you can bag kids for basically ever. But there are a few situations in which it's fair to anticipate a difficult airway, and this is one of them. You're going to see a lot of swelling in there, and the landmarks may not be clear. Certainly a child with a giant hemangioma like this may have a difficult airway. And look at the syndromic child. Any kid with a syndrome that involves a small jaw and a big tongue, that is going to be your pediatric equivalent of the 400-kilo man with a beard. It's going to be a tough intubation. And certainly somebody who's going into it cyanotic is going to desat very quickly and be difficult to pre-oxygenate. Now, we know that appropriately pre-oxygenated adults can sit their apneic for a long period of time before they desat. You could practically go get a cup of coffee and come back and intubate your adult patient. But it's not so with kids. In a study that looked at well children, no respiratory problems, getting pre-oxygenated in the operating room for an elective surgery, like a hernia or something completely unrelated to the lungs, when they left infants apneic, they desatted in 96 seconds. Preschool-age children, it took them 160 seconds. Now, this is probably time for a couple attempts at intubation, but remember, these are healthy kids that were adequately pre-oxygenated. Here you have a kid that might be difficult to pre-oxygenate and clearly has some pathology going on, and those are the kind of kids that we intubate. So what are you going to do? Well, obviously you want to pre-oxygenate them to the best of your abilities. This idea of apneic oxygenation has come up a few times. I don't know if any of you read the article by Scott Weingart a few months ago in Annals discussing adult difficult airways, but he talked about this concept of putting a nasal cannula in, jacking it up to about 15 liters, and just kind of spraying oxygen at the patient while they're apneic during your intubation. I looked to see if there was any literature in children, and there's not, but I have to say I've tried it a few times, and with my N of 3, it's gone very well. Obviously, you want to try to pre-oxygenate them with a non-rebreather, bag valve mask if you have to, and certainly if none of that's working and you really can't pre-oxygenate the kid, you're not going to have much time. So you might actually want to sedate them, paralyze them, and try some non-invasive positive pressure ventilation, or even consider pre-oxygenating them with an LMA, and when they're pre-oxygenated, replacing that with an ET tube. With kids that have upper airway obstructions, one thing that you might notice is that they're kind of holding their own while they're sitting up. If you think of that classic picture on the boards exam, the kid with epiglottitis, they're tripoding, they're sitting forward to try to keep their airway open, right? So what do? We sedate them, we paralyze them, we lay them down, they completely obstruct, and then we try to pre-oxygenate them. So there are a few small case series of taking kids and actually putting them prone with their head over the edge of the bed and pre-oxygenating them by bag valve masking them while they're prone, and gravity helps you to relieve that obstruction. It sounds complicated, but remember, it's not a 400-kilo guy. This is a 10-kilo baby, and it's pretty easy to flip them back over once they're pre-oxygenated. The other thing is to, of course, be ready with a backup device. I'm sure a lot of you guys have video laryngoscopy in your emergency department, and there are pediatric-sized blades that come with almost every video laryngoscope. Just check and make sure your emergency department has them. At County, we had a glide scope for years and years and years before finally one of the pediatricians said, hey, where are the size 1 and 2s? I can't find them. And we realized no one had ever ordered them. So it's very simple to do. You can use the equipment you already have. LMAs are great rescue devices. They've got tons of sizes, and you can use them all the way down to 2 kilos. So a difficult airway in a baby born in the emergency department, you can use an LMA. There's not a lot of literature on awake fiber optic intubation in kids. It is an option. It's fairly difficult. And transtracheal jet ventilation, we discussed this at dinner last night. I think between all the pediatricians there, we've done it just a couple times. You will probably never do it. Nonetheless, it's very simple to do with equipment you have easily accessible to you in the emergency department. So if you're ever called upon to do what should be a surgical crike, but it's a child under 10, so you can't do a crike, and you need to do transtracheal jet ventilation, just grab a 14-gauge IV, plunge it at a 45-degree angle through the cricothyroid membrane, and stick in a 3.0 ET tube adapter right into the hub. You can bag right through that. If you don't have a 3.0 ET tube adapter, you can do what's done in this picture, which is pull the plunger out of a 3 cc syringe, hook that up to the hub of the IV catheter, put a 7.5 ET tube adapter on the top, and bag through that. All right, so what happens? Your patient's intubated, and up flows tons and tons and tons of pink frothy secretions. The chest x-ray shows good position of the ET tube, but pulmonary edema. So what happened? Well, we know that airway obstructions can cause pulmonary edema, and in the old literature, from the time that epiglottitis was rampant, 2 to 10% of significant upper airway infections actually resulted in pulmonary edema. There's several reports in Croup and several reports in spasmodic Croup as well. Now, if you have a kid with severe croup in the emergency department, I'm not saying that you have to admit all of them if you can control them on racemic epinephrine and steroids because of the risk of pulmonary edema. Certainly, you're going to be watching those kids for a few hours anyway, and typically, pulmonary edema will manifest within 90 minutes of you fixing the obstruction. The treatment is going to be supportive, just like you would for anybody else with non-cardiogenic pulmonary edema. Now, what are some other things to think about? What else could this have been? Well, certainly, we worry about bacterial superinfection, bacterial tracheitis being the big thing. And I kind of think of bacterial tracheitis as croup on crack. The kid comes in looking like a crouper, but they're really febrile. You have a really difficult time controlling them. And even if you can get the stridor under control with a little bit of racemic epinephrine, they relapse fairly quickly. And you're going to finally diagnose that when you eventually intubate the child and tons of pus comes pouring out of the ET tube. Epiglottitis is fairly rare in this era of vaccines, but there certainly are a lot of kids, at least in Los Angeles, who are too good for being vaccinated. And there are non-H flu types of epiglottitis. And some of the other neck infections, like retropharyngeal abscess, can also present with these same symptoms and cause stridor as well. Now, I mentioned that croup is most common in kids from 6 to 36 months. Of course, you can get croup in a kid younger than 6 months, but when you have a kid younger than 6 months, there is a long differential for what might be causing stridor, a lot of different congenital causes, some of them like laryngomalacia being pretty benign, but you can have kids with vocal cord paralysis or papillomas that are pretty sick. All right, next case. The next case that I had in this talk was actually an asthma case, and as I was like halfway through writing the case, I went to a shift, and this kid came in. And I thought he was rather frightening and really interesting, so I actually swapped the cases. This was a 10-year-old boy who presented with shortness of breath. And he had had a one-day history of fairly acute onset, worsening shortness of breath, and very mild chest discomfort. Review of symptoms was negative. No fever, no cough, no antecedent illness, nothing. His family history was positive for asthma, but this kid had never wheezed. The family was concerned enough to call the paramedics, and when they got to the house, he was satting 80. They started oxygen, and when he got to me on oxygen, he was satting 100. But remember, this is a 10-year-old, and he's tachypnic and tachycardic. He's breathing about 56. And his exam was otherwise normal. Lungs were totally clear. Oh, now that's working. So we did our bedside ultrasound, and here's what we saw. Bilateral pleural effusions. And then we decided to take a look at the lungs, and we saw these lung rockets. So now we're thinking bilateral pleural effusions and pulmonary edema. Write some initial orders, labs, EKG, imaging. I decided to give a trial of albuterol for no apparent reason, just to maybe buy me some time to think about it. IV, monitor, advanced airway equipment to the bedside. I ran to tuck in a few other sick patients since I knew I'd be spending a lot of time with this kid. I come back. Now the kid's breathing really shallow and breathing 60 and looks horrible. We get a chest x-ray. It confirms our suspicion of pulmonary edema. So what's going on? What's the differential diagnosis for this kid? Well, certainly we can think of some pulmonary causes. It's not a great story for pneumonia, but you could have pneumonia with effusions. Pulmonary embolus is rare in kids, but it does happen. Cardiac, myocarditis. Occasionally you'll have a right to left shunt like an ASD that remains asymptomatic through childhood and then becomes symptomatic when the kids are more active in adolescence and presents with dyspnea on exertion. This kid's a little young, but it could happen. And then there are the extracardiopulmonary causes. Does the child have glomerulonephritis and fluid retention? Maybe they had a recent episode of strep. Is this a kid with nephrotic syndrome and really low albumin? Maybe they're in renal failure. I don't have a great reason for ARDS, but I suppose it could happen. And we don't get a lot of 10-year-old heroin addicts, but obviously we have to throw some type of a drug-induced non-cardiogenic pulmonary edema onto the list. Here's your EKG. Now, I'm no mama too, but I can tell you that this is not normal. So in kids, we typically will see a juvenile EKG pattern where you see a T-wave inversion in V1, and you can't actually see the T-waves invert all the way through V4. But they aren't usually inverted in V5 and 6, and typically the inversions in V3 and 4 are pretty small. This kid has pretty marked T-wave inversions across the precordium. Something's going on. So your labs come back, your CBC, your chemistry, albumin, urinalysis, urine tox, they're all normal. Your troponin is negative, but wow, look at this BNP. It's really quite elevated. And the D-dimer is not normal either. So what does this do to my differential diagnosis? Well, most of the non-cardiopulmonary causes are, at least for the most part, off the likely list. I'll admit it, I was a wimp. I got a CTPA on the kid, and it turns out they didn't have a PE. And so we can kind of tentatively take pneumonia and pulmonary embolus off the list based on the CT, which leaves us basically with our cardiac causes. Myocarditis is the most common cause of heart failure in a previously healthy child. In developed countries, it's mostly going to be viral from things like parvovirus or Coxsackie, and it typically will follow the viral illness by a couple weeks. It's certainly not common, but it's not that uncommon, and we see it in about 2% of pediatric autopsy cases. Half the cases occur in infants under 1 year, so that's a particularly high-risk group, but it can happen all across the pediatric age spectrum. And most kids, about 80%, will survive with a good cardiac outcome. However, it can cause sudden death, and it can, if the child lives, progress to a dilated cardiomyopathy. Presentations are myriad. It can be anything from asymptomatic to a flu-like illness to CHF, arrhythmias, or, like we said, sudden death. And as a result, 84% of these kids are misdiagnosed on their first presentation. And when they are misdiagnosed, usually it's going to be with something like asthma or pneumonia. Now, there is a classic history that you might get, and if the kid presents classically, you're going to get a history in an infant of anorexia, abdominal pain, vomiting, lethargy, or syncope. And you can see how this can be very nonspecific. In an older kid, hopefully they'll localize it a little better for you, give you some history of chest pain, dyspneas on exertion, fatigue, palpitations, and maybe arthralgias. And when I went back and asked this kid, he had actually been taken to his primary care provider by his grandmother twice in the week prior because of severe arthralgias. The physical exam in myocarditis, unfortunately, can be really subtle. Things like tachycardia, fever, abnormalities in the lung exam, and respiratory distress only occur in about a third of cases. Hepatomegaly and tachypnea occur about half the time. So how do we diagnose this? Well, none of these tests are perfectly sensitive, but you may get some hints on your EKG. You can see some ST-T wave changes. You can see Q waves. You can see blocks, or occasionally a low-voltage EKG. Your chest X-ray is frequently going to be abnormal for pulmonary vascular congestion, pleural or pulmonary effusions, or even just cardiomegaly. Troponin may be helpful, but don't exclude it based on a negative troponin. The sensitivity is only about 70%, and this applies to CK as well. BNP hasn't been studied well. It might be helpful, but it could still be negative. Now, typically, kids are definitively diagnosed on echocardiogram. If you have easier access to a cardiac MRI, that might do it as well. And obviously, in a child who's not responding well or it's a questionable case, they can go to myocardial biopsy, but that's rarely done anymore. The treatment is going to be symptom-specific. You're going to use diuretics if they're fluid overloaded, furosemide 1 milligram per kilo. If you need some inotropy and some afterload reduction, perhaps your kid's a little bit hypotensive, you can use things like dobutamine and milrinone. I was actually shocked that the ED pharmacist was willing to bring me milrinone. And sometimes people will still use digoxin. IVIG has been fairly heavily studied, and it doesn't seem to work outside of myocarditis from Kawasaki's disease. And there's a lot of stuff that these kids might get on the floor that's out of our scope, antivirals, interferon, that sort of thing. And certainly if a kid does have a block and they're symptomatic, they may require temporary pacing. Now, I just want to take this opportunity to remind you that children are, in fact, little adults. If you see an adult, an 80-year-old woman, come into the emergency department with shortness of breath, you're going to rule out an MI. You're going to think cardiac causes. And I would encourage you to think that way for pediatrics as well. There's a lot of different cardiac causes of pediatric shortness of breath. In neonates, you can worry about the ductal-dependent lesions. Perhaps they have some type of a cyanotic cardiac disease. Certainly, we can see arrhythmias, such as SVT, sending kids into heart failure. Myocarditis is common in the under 1 set. In infants, all of these same problems can appear. 2 other things to mention. At about 2 months of age, a lot of kids who have right-to-left shunts, like VSDs or PDAs, become symptomatic with heart failure, so that's certainly something to think about. And it's odd that MI is on the list, but there are kids that are born with congenital abnormalities of their coronary vessels, and they can present in infancy with an MI. So as difficult as it is to get an EKG in one of these little kids, it's not crazy if you have shortness of breath in a child and you can't figure out why. In a school-age kid, it's pretty much going to be myocarditis. There aren't a lot of other cardiac lesions. And when you get to adolescence, of course, they can have myocarditis as well, but then you start to deal with things like hypertrophic cardiomyopathy, ASD, arrhythmias, and again, MIs, not only from the congenital abnormalities in the cardiac vessels, but also from drugs and other things that tend to impact teenagers. Thank you. I hope these cases woke you up as much as they woke me up, and I certainly appreciate your time and your attention.